Narcolepsy type 1, also known as narcolepsy with cataplexy, is a biologically understood central disorder of hypersomnolence with objective testing. Why then, you ask, is it misdiagnosed the majority of the time? I'm Dr. Andy Berkowski of ReLACS Health, and in this part 1 of 2, I will go over 15 reasons why narcolepsy type 1 is commonly misdiagnosed. For more detail on this, please click on the link below to read my extensive blog article on this topic. But let's get started. Number 1, there is an army of untrained sleep specialists out there. Narcolepsy type 1 is a very rare condition, maybe 0.001% of the population. And for many years, there was no fellowship training to become a sleep specialist. Anybody could just sit for the board exams. There were physicians who have no on-the-job training or experience, and they may not have the knowledge or skill to diagnose narcolepsy type 1. Number 2, there is a poor understanding of what cataplexy is. I touched on this in another video. Cataplexy is a temporary loss of signal from the nerves to the muscles. The muscles sort of give out for a split second to at most a few seconds. Cataplexy is not seizures, it's not passing out, it's not falling asleep, it's not feeling weak. And this is often misconstrued mostly by providers and patients. Number 3, there's an assumption that some of the symptoms of narcolepsy only can occur in narcolepsy. For example, sleep paralysis. An individual can wake up in the middle of the night, usually toward the end of the night, and feel like they're trapped in their body. Their brain's waking up, but their body's paralyzed. This just happened to me a few weeks ago. It can happen to anyone. It can happen to people particularly who are on irregular sleep schedules or people hitting the snooze bar too often. Sleep paralysis is pretty common in narcolepsy, but it can affect any individual. Many other symptoms of narcolepsy can also be seen in healthy individuals as well. Number 4, it's a logical flaw to screen for exceedingly rare conditions. In a sleep clinic, they screen for sleep apnea, restless leg syndrome, insomnia. These are large percentages of the population, and at the same time, people are screening for these exceedingly rare conditions like narcolepsy. So if you screen for something you're not supposed to be looking at, well, you might start to identify people who don't really have the condition. So that's kind of an issue in our field right now. Number 5, the multiple sleep latency test. This is a series of naps that are done 2 hours apart to try to identify narcolepsy. It's a test that's completely erratic. It's completely nonspecific. By nonspecific, I mean that the results may look like somebody with narcolepsy, but really anyone can have those results if the right situation takes place. For example, someone who's on an erratic sleep schedule prior to the MSLT might have MSLT results looking like someone with narcolepsy, but they don't have narcolepsy. So it's another false assumption to think that the results of the MSLT mean that you have narcolepsy. There could be some evidence supporting a diagnosis, but it does not guarantee that that's a diagnosis that's correct. Number 6, the MSLT is prone to human error. I've encountered numerous times where it's been misinterpreted. It's a human test. It's interpreted by looking at a bunch of squiggly lines and determining whether a person fell asleep by looking at their brain waves, or if they went into rapid eye movement sleep by looking at things like eye movements. Some people have mistaken people on their cell phone with their eyes scrolling up and down on Facebook as rapid eye movements, and the person's wide awake. It is prone to human error. Some of these tests are actually misinterpreted. Number 7, has anyone heard of the HLA-DQB10602 allele? That's a mouthful, but that is the human leukocyte antigen that is directly linked with narcolepsy. It's part of the immune system, and it helps lead to destruction of the hypothalamus, or the part of the brain that produces a chemical called hypocretin. Well, this human leukocyte antigen is necessary to have narcolepsy. So if someone doesn't have this HLA, they cannot have narcolepsy. It is almost 100% sensitive. So a negative test would rule it out. And it's a simple, affordable blood test, and it's not done very often. I'm going to pause there, and we'll go through numbers 8 through 15 in part 2 of this video, and that will be posted shortly. As always, this is for general medical information only. It does not constitute the practice of medicine. All medical decisions should be made under the direct supervision of a licensed medical professional. And one of the keys to sleeping well is to relax.